A very good morning to you all. I would like to apologize beforehand for any technical glitches, but we are definitely trying our best to deliver. This is Devina Sharma, and I'm Deputy Director of International Relations Council, and it gives me immense pleasure to have you all on board for IRC's first ever virtual bench. Today's webinar is going to be on COVID-19, wherein we have participants and speakers from various walks of life and the medical fraternity who will be sharing this experience that they have gathered from dealing with patients inflicted with the pandemic. With us today, we have as our mediator Mr. Pratim Ranjan Bose, Deputy Editor of the Hindu Business Line, who will be mediating the entire session. His encouragement and push from the very beginning, from the inception of the idea of this webinar, has led to this day. So I would really like to thank Sir for his involvement. After saying that, I would request Sir to take over the rest of the session. Thank you very much.
Thank you, Devina. Thank you, IRC, Shoitkot, Joita, and everyone, our speakers, Dr. Shivabroto Banerjee, Sister Janaki Ram Santi, Dr. Jyoti Thapa, Dr. Shuman Thapa. I think there's a lot of audience from Nepal. We have already crossed, I think, more than 1.5 months in home arrest. Doctors are busy. We journalists are also somewhat out on the street on the list of affected. So the background is known and the doctors are here. So this was primarily planned as opening a platform for doctors in the region to exchange notes between them, because as a layman, what we have noticed from the beginning in this whole discourse is that there has been a lot of ambiguity, which is understandable because it is a completely new animal. Whether it is a pneumonia, whether it is the symptoms are, I think it just evolved. That has been the case. With the situation now is that the statistical background is more or less known. We were around less than 200 cases per million population in April, around mid-April. From there, we are now close to 1,000. The frequency for getting COVID cases reported against tests, tests to case, number of tests for each case has really improved, which means that the concentration, we had been successful to whatever extent in containing the disease. Now that every country in this region is on the mode to withdraw the lockdown phase. And we read yesterday the version of AIMS doctor who feels that, and it was quite under discussion that about the second wave. So the doctors, we will request all the doctors to exchange notes themselves about what are the issues that, pertaining to general public, like us, commoners, and so how and what things can the doctors look into, doctors and sisters, Sister Janaki Raman. With that, let's start the round, and may I first invite Dr. Shivabroto Banerjee to share his thought.
So let me start with just one or two statistical ideas. See, we have increased our number of tests in India. If we concentrate only to India, we have started from 191 per million, and now we have reached almost 936 per million tests per day. So we are almost doing 85,000 tests in a day. So, but if we convert it per million or per thousand in comparison to the other countries, it is so less, it is not even statistically significant. But if we consider regarding the total tests, then we are fourth or third all over the world. So our main challenge is our Indian population, which is almost 138 crore, and our population density, which is almost 506. per square kilometer in comparison to the states where it is around 36 per square kilometer, or in the Italy where it is 206 per square kilometer. And you will be surprised to listen in West Bengal, our population density is over 1,000. And in Calcutta, you will be again surprised, our population density is 24,100 per square kilometer. So if you go through the papers, you can understand our containment zones are rising like anything within the red zone. So from this data, I can tell you yesterday from AIMS, Dr. Guleria, or on 4th May, Economic Times and in Times of India, Indian Association for Cultivation of Science, which is Kolkata-based institute, they have given one mathematical model where they projected the highest rise of newly infected cases will be at the end or first week of the July. And I am telling you, this is not the second wave. This is the continuation of the first wave. We are yet in the rising phase of the first wave. We have not even reached the plateau phase of the first wave. So regarding whether we will leave lockdown or will continue lockdown, this is not only an issue of the medical science, it is an issue of socio-economical status, and economists and administration, everyone will take that decision. That is beyond my point of discussion. But only I have shared my view regarding the statistical part. Now let us come to absolutely to our science. What is going on right at this moment? It is perfectly true. 80 to 85% of the totally infected person are asymptomatic. So asymptomatic burden is huge. The symptomatic burden is almost 15%. Now the out of symptomatic person, serious persons are almost 15%. And out of serious person, according to the statistics all over the world, after 14 days, 15% of the serious persons are usually dying. So this is the almost case fatality of these cases. Now regarding all these statistics, what we are getting right at this moment, these are tests done on the patients who are either admitted in the hospital or coming to the hospital with perfect symptoms or with suspected symptoms, rather I should tell you. But we do not know what is going on in the remote community. So if we can extrapolate the data of the community, then we can only understand the trend of the epidemiology right at this moment. Let me enter into the clinical part. The patients who are getting admitted, a lion's share of them are mildly symptomatic. But yet, I am a bit confused. We are admitting mildly symptomatic patients in our hospitals all over the India. But by that, we are decaying our health resource. Even after having an idea from Ministry of Health, we can treat those mildly symptomatic patients in the home. But there are a lot of fallacies. Number one fallacy is we cannot do doorstep investigation, even we cannot do investigation outdoor based. So if I cannot do doorstep investigation or outdoor based investigation, and for investigation, if I have to admit the patient, then how can I treat that patient in home when he or she is mildly symptomatic? Next part regarding the testing, yet you know everyone is having the information. We do not know right at this moment the status of rapid antibody test. And for our clinical treatment, there is no role of rapid antibody test. We are totally dependent on RT-PCR. And there are lot of protocols what we have to follow, particularly in the form which we are provided by ICMR, and Annexure A and Annexure B. If we go through that we have to follow perfectly. So we are following that, but for getting the report, it's all are very much time consuming. So in a 138 crore country, this type of protocol, following this protocol we must follow, but that should be far more easier, I think so, to cover the big country. Now coming to the treatment part, regarding treatment, we are following a standard protocol provided by Ministry of Health India, Ministry of Health and Family Welfare India, and ICMR also, and partially WHO. So every state, every hospital is slightly individualizing the treatment protocol, but mostly we are starting with hydroxychloroquine and azithromycin, continuing treatment for 5 days, sending again RT-PCR test. If it is negative, we are sending after 48 hours another test. If it is negative, then we are discharging the patient or keeping the patient if the patient is having some symptom for next 14 days, and then we are declaring that patient is negative. But after treating with hydroxychloroquine and azithromycin, if after 5 days if we see the patient is yet positive, we add lopiimmune, that is ritonavir lopinavir combination, and we are continuing it for next 12 days. But again on day 5, we are sending RT-PCR test, and if it is positive, we are continuing it till 12th day. And if it is negative, yet we are continuing it, and we are repeating the test after 48 hours again, and we are discharging that patient with the advice of lopiimmune and advising to continue it till 12 days. Now, if yet we see this patient is not improving, rather deteriorating, we are sending this patient to our ICU isolation for COVID. And there we have tried a lot of things, but we are first what we are doing, we are trying awake, supine and prone position. With proning, the patients are really improving. Then if not improved, we are definitely supplementing oxygen. We have tried a lot of methods. We have given simple nasal cannula oxygen. We have given face mask oxygen. Even initially, in our ICU, high flow nasal oxygen was not indicated because its propensity to generate lot of aerosol. But with precaution, we have given HFNO, and we have seen lot of improvement, and we have given face mask oxygen with 10 to 14 liter. We have seen lot of improvement. Then even it is not improved, patient is not improving, then we have given non-invasive ventilation, though there are a lot of initial queries in non-invasive ventilation regarding its propensity to generate aerosol. But later on, lot of papers and lot of studies, and even there is a recommendation from International Pulmonologists Association, and we had a big webinar on it, and we have tried with NIV, and we have seen lot of improvement. And the later part, if we have seen the radiologically patient is deteriorating, if we see the clinical prognostical marker, we are testing regularly, those are deteriorating, then we are going to intubate or ventilate the patient. Now, regarding the prognostic marker, my interesting observation, which I have ignored initially, we know the prognostic marker, we are doing CRP, ferritin, LDH, D-dimer, all these. But interesting observation is, we have seen in a good number of patients, D-dimer is more than 1 lakh. And I have seen in my own eyes, the fingertips are getting blue and radial artery getting absent. And I am having the photograph, and I am having that patient who is going to self-amputate his own 2 fingers. So that is very interesting observation. And do you know, I was observing last night, there are few papers are coming in Italy, 50 patients died on whom autopsy done, and they have found pneumonia is not the main reason of COVID catastrophe. Rather, coagulopathy is getting the main highlight of the COVID. So our protocol of treatment, what we are right at this moment sharing with everyone, or we are trying to follow, that is number one, we are definitely giving some antiviral. Definitely, we have tried with anti-inflammatory. I have at least tested on 10 patients IL-6, and interleukin-6 level I have seen in few patients more than 700. And in those patients, we have given tocilizumab, and I have tried tocilizumab. I have given 400 milligram stat, and after 12 hours, in few patients after 24 hours, and in few patients after 48 hours, I have given. My observations I am not yet disclosing because these are all in our record section. We are keeping it, and our IL-6 is done by our Institute of Child Health, Paksakas, Kolkata. So we have all the records. So we are giving anti-inflammatory along with antiviral. We are adding antibiotic if procal is rising, and we are parallelly giving anticoagulant. So we are following basically 4A: antiviral, antibiotic, anti-inflammatory, as well as anticoagulant. Now regarding anticoagulant, we are starting heparin in a very low dose. Sometimes we are escalating the dose, and sometimes we are trying with antiplatelet also. So in a nutshell, what I want to share with you, just only one idea. What we have seen, the patients who are getting intubated, our idea is chance of death is more than 80%. So the idea, now the papers are also coming. The intubation ventilation is not the only cornerstone of therapy in COVID. Rather, initial idea was early intubation and ventilation. Now the idea is getting changed. As late as possible, you try to intubate and ventilate the patient, and try to keep your patient off ventilation as much as possible. This idea is globally changing, and it is our first-hand experience what we are getting. Really, the patients who are getting intubated and ventilated, his or her lung is getting really worse and worse. Thank you very much giving me an opportunity to describe.
So Dr. Banerjee has picked up certain issues. And one interesting thing that I find is that about this, one is the protocol for RT-PCR test. This one we heard, and that the how to reduce the load on hospitals, as we are now going to see increasing number of patients, and our infrastructure is not capable to serve that. So may I request Dr. Krishnamurthy to please enlighten us.
Good morning, all of you. I think I'm speaking to all really involved people there. So I thought it will be very practical to talk about our experience, and if at all some useful discussion, if it comes through this, we will implement all those things actually. So I'm representing Apollo Chennai, and I want to fit my talk into the following headings, like what is the trend in Chennai now and how we are going through. And second one is what is our protocol. Third one is regarding how do we manage the categorization and how do we manage. I just want to divide this into these four topics now. The trend, if I say that initially to start with, actually we started admitting from March, middle of March onwards. Initially, to start with, it was on a lower trend. Actually, we were very cool. We were very few patients. We were a little relaxed. It was like that. But the trend was gradually started rising. Suddenly, it has taken a bloom. You see, See, the reason for the bloom is, as everyone is expecting, on as Subrata Banerjee was saying, that it is really looking like an epidemic actually now. See, the probable reason, because of the increasing number, every state has got a trigger or cluster. Every state has got some particular reason. In addition to the nation causes, there are certain triggers pertaining to the state actually. We, as Tamil Nadu, we have got our own triggers. I do not want to mention any of the triggers now. It may not be apt to talk in this platform. There are certain triggers pertaining to each state. According to that, numbers vary. We are just going through the maximum number now. We are really having a tough time actually. And second thing I would like to focus upon is the protocol what we follow. We have a fever clinic, and fever clinic has been we have a protocol which has been designed, of course, with the ICMR guidelines and Ministry of Health and Family Welfare. The Apollo has designed the protocol, and we, as rightly pointed out, Subrata Banerjee, this is a new disease. I think the chairperson mentioned it's a new disease. We have to update our protocols. Other disease have a fixed protocol right from day one. But as far as this coronavirus, this COVID is concerned, we have a changing trend, a changing, and we have a red book which we release almost every 7 days. We release our now red book version 5 is on flow now. And according to this protocol, we have a fever clinic, how we categorize the patient. I think everyone will be aware of it. We initially was running through the manpower. Now we even take a video consultation and run the fever clinic. If necessary, we send them to ER to assess the patient too. And we categorize them. We send the category A and B1 to home. And surprising is that the even category B1 patients, even if they have a cough, continuous cough, they come back to our ER for requesting for admissions. I think that we have to, as you said, your experience, I thought this I have to share. Though we strictly adhere to category B2 and C, sometimes category B1 patients who are really very nervous, we may have to occasionally admit them, or when they are attenders of some family members, and one of the family members is very sick with the ventilatory support or an IV, I think it's right on our part to admit some category B1 also for observation. This is what is our experience. And third part is that regarding the IP management. IP management, we have consultants on rotation. We have internal medicine people. We have pulmonologists. And I think I should thank that Apollo, other units also is supporting, giving consultants for our rotation. And we do it on rotation. We have a common COVID group. We share the patient's problems, and then anybody has a problem, we just put it in the group and anyone can come through. And I should be failing in my part if I say infectious disease also in our group. They do the rotation. They also come in rotation. They see the patients daily. We have our inputs, and in our COVID group, I think we have physicians, pulmonologists, infectious disease, and radiologists and emergency physicians, ER physicians in our COVID group. We always tell, as soon as the patient is admitted, we tell them, I'm admitting this patient. Patient requires a CT. Immediately, radiologist will come. He or she will gauge the technicians, and immediately the CT findings will be displayed in our group. We really fix our treatment right from the time the patient enters the doorstep, actually. So the ER is doing a very good job dividing the patients into stable. Of course, the stable patients go through a CT and then they are shifted to the ward. Unstable, of course, they intervene, they intubate, or they start on inotropes. And and surprising thing I would like to mention is that, of course, we do not know whether the patient who is coming sick is COVID or non-COVID. And I should say there are equal number of non-COVID patients, unstable patients are getting admitted. I think we should take a point that to tackle these people also, and we should know where to keep them also. Of course, stable patients, we keep in a suspect area. We have a suspect area where one-to-one nursing is definitely there, and we keep it in a suspect area. Of course, unstable, it's very difficult whether we can't have a suspect ICU or a non-suspect ICU. We have a common ICU, of course. We have one-to-one nursing there, and we have 3 floors with ICU setup. And of course, I forgot to mention, in our critical care group also is part of our group, and they also the critical care group take care of all unstable patients and display in our groups about their positions. And regarding the coming down to management, I think I thought I should cover all aspects of what we do. So it's not the time that we should discuss theoretical part and trials part and studies which come, and then if we share our experience, the plus and minus will be discussed in the group. I thought it is apt to discuss about. Regarding the management aspect, stable patients, generally category A, of course, we don't treat. Category B1, I said occasional admissions we are making through, and those patients we put on HCQ after a cardiac evaluation. So the findings in papers, findings in our medical groups, findings in trials say that the starting on HCQs on the problems of this QTC prolongation on all is very risky nowadays. I think the patients go through the cardiac evaluation. We start the patients on HCQs, hydroxychloroquine. And regarding the B2 and C, we really assess them on the respiratory support and look at the CT findings. How is their ventilatory state, that is hypoxic status and oxygenation. I think our residents, we must be thankful to our residents and registrars who are doing a fantastic job giving the updates on patients. We do start on IV antibiotics when we are not very clear whether it is a pneumonia is because of COVID or non-COVID. Of course, we start on any other cap regimen which is in our protocol. We start on antiviral when we feel it is a viral pneumonia. That is oseltamivir we start with. And as it was brought up by Subrata Banerjee, that the coagulatory part is very alarming. We have seen n number of patients, that means I should not say n number of patients, almost more than 50% of patients with higher D-dimer value. And more than 2 times of the D-dimer value has been in our protocol, and we start on anticoagulants. And we usually start with heparin. Patients with the CKD, we start on conventional one, unfractionated, and other patients we start on low molecular weight heparin. Of course, the patients are on conventional heparin, unfractionated heparin. We check the coagulopathy frequently. And I've just read in a latest update, up to date, that all patients who are better to start on anticoagulation. This is what in the latest up to date, which has come just 2 days back. Better to put them on anticoagulation. I think we should try that. Right now, what we are doing is we are putting on anticoagulations in patients who have more than 2 times of this D-dimer value. I think we have to consider in our group, and we should have a consensus. Should we put a low molecular weight heparin on all patients who are in B2 and C? That is yet to go through. And if in this consensus, if we get this, and as well as let me continue in the treatment perspective, that the maximum, there are, according to the up-to-date and reports, all these drugs, specific therapy, if you want to, all the specific therapy are all on investigational basis only. Everything is on investigational basis. Nothing has been proven to be the drug for treating COVID virus. Anything you take in vitro, it is very good. Hydroxychloroquine in vitro, it has been very good. SARS, it has been very good. So you can try. And this is what they have been talking about. Even be it hydroxychloroquine, be it azithromycin, they're saying there are studies which combine these two also, hydroxychloroquine and azithromycin. And as far as this remdesivir is concerned, it is an investigational drug. And it has got an emergency approval in United States based on a trial. They have found a marginal improvement in mortality benefit in US. Though in Chinese study, they have found the remdesivir has not been finding a good effect on mortality. And as far as this antiviral combo is concerned, as far as this remdesivir, I think the Chinese study is not supporting a good effect on mortality. I think we are just welcoming the drug in our Indian setup. I think there are certain pharmaceuticals which are really into making of the intravenous drug. I think it's a parenteral drug which we are yet to receive it, and when it comes, we'll also put into the investigational trial. And with the, of course, the consent that the antiviral combo which Subrata Banerjee, we are not using that, to be very frank. One antiviral we are starting is oseltamivir. We are starting anyway. Once RT-PCR for H1N is negative, we are stopping that. And when the COVID is negative, still it is a viral pneumonia, we complete the course of 5 days of oseltamivir. And regarding the drug which is in investigational basis, we are using in plenty is tocilizumab, is what is Subrata Banerjee was talking about. When do we choose this tocilizumab? So we look into the 3 parameters, looking into the respiratory aspect actually. Patients who are going down with hypoxia, and patients who have tachypnea, and patients who have more than 50% of involvement in the HRCT. I think we should thank our radiologists who are giving the CT severity index. When the CT severity index gives more than 50%, we choose these 3 indexes and then go for IL-6. One testing of IL-6 is not enough. I think in these patients, one IL-6 is marginally high. We keep repeating it at least once in 2 days when the IL-6 is mounting high, and then we go for tocilizumab. Almost for 10 patients we have used. I think I should tell about, for this duration, we have been having 210 patients. Among that, positive patients were 75. Almost 1/3 of the patients, we have had a census of positive patients. And those 25 patients, that was 1/3 we have discharged among the positive. And death was 4 in our group, in our hospital. Intubated, totally 7 patients were intubated. And we have made a successful intubated patient. 1 patient so far, 2 patients successfully extubated. And 1 patient in a tocilizumab requiring a non-invasive ventilation has come out even without going into the invasive ventilation. And we have made successful discharges of 120 patients. And I should tell you that COVID death is 4, non-COVID death is 8 in our hospital. I think it is pertinent to discuss in our group that non-COVID death is very, very alarming. By looking at COVID like that, I think we should never belittle non-COVID patients, and we should keep a better eye, or we should keep a special eye on these patients who are unstable, non-COVID. I think it is our duty to prevent the non-COVID people also. I think the trials basis, we have plasma transfusion. ICMR is yet to give approval for that, and remdesivir, which I have already mentioned. I think regarding the healthcare personnel and other things, I think we have our nursing director, Shanti, to discuss about the strategies and healthcare workers. How do we manage about, how do we prevent this infectious control and other things? I think I am fitting in the time. Right, sir, moderator, sir.
Thank you, sir. So let's now go to Sister Janaki Raman.
Hello, namaste.
Yeah. So before we go, just a request to all the participants, to whosoever has question, please start putting it on chat box, since the doctors are busy there on a war front. And so let's now go to the sister. And we have an alarming trained sister in everywhere, I believe, and we see it in Calcutta, where the health staff are getting infected in very large numbers. Just the other day, some 15 nursing staff of a hospital got infected. So we are eagerly waiting for your views on this.
Namaste. This is Janakiram Shanti, Assistant Nursing Director, Apollo Specialty Hospitals, Vanagaram. Our COVID journey started first week of March 2020. Apollo Hospital initiated the first step of creating awareness on COVID-19, which includes of regular week-on, peak-on regarding the facility available at each Apollo and preparedness required for suspected and confirmed COVID-19 cases. Thereby, Apollo warriors step into the management of COVID-19. Training were given to all our employees, irrespective of their working area. Our management helped us in each step of milestone towards managing the crisis of COVID-19. I would like to mention the contribution of each department. First, our management consultant, our consultants and the ID team created the SOPs and policies on COVID-19. The group of people identified and given with responsibility for taking decision towards managing COVID-19. The team includes of Dr. Krishnamurthy and myself. I also extend my thanks to government because as a nodal officer of Apollo Specialty Hospital, Vanagaram, it gave me the clarity in handling of COVID-19 crisis in my organization. Our pharmacy and surgical stores ensure the adequate availability of PPEs. The floor and floor were earmarked, and our engineering department converted the entire wing as a negative pressure with the isolation rooms, which is very important for this crisis. Our nurses were trained and also motivated for managing the COVID-19 patients. Infection control team along with the nursing team, screening process initiated before entering to the hospital, and the identified persons are transferred to fever clinic, symptomatic team. To minimize the cross transmission of infection, video consultation facility created by IT team. Thereby, with the help of all departments, though we had few obstacles, we are managing the crisis also. Also, I would like to mention about receiving various category of patients, which Dr. Krishnamurthy was talking. Such a patients, whether they are rich or poor, young, elderly, maybe geriatric, vulnerable group, every category patients handling is a big challenge for our team with their emotions. As we all know that people believe this is a deadly disease. They are undergoing stress, anxiety, and high pressure. We amplify hopeful stories and positive images of people who have experienced COVID-19. In this juncture, I'd like to mention few of the members who was really very critical. An elderly person around 90 years old lady got recovered from COVID and happily joined to the family. She was really happy. We don't know how to express her feeling and our feeling in that. We also ensure that our nurses are taken care well by providing prophylaxis and self-screening. We provide a comfortable environment and healthy food, the quality and quantity being monitored by our nursing supervisors. Though we offer everything for our nurses, there are some of them were really little stressed. The young girls, they need a little more attachment from everyone. Our unit head, medical head, and myself talk to each employee frequently and address their problems and motivate them to overcome the crisis situation. Though we offer everything with the wearing of PPE, helpful coping strategies such as ensuring sufficient rest, providing healthy diet, engaging in physical activity, and stay in contact with their family and friends. I really thank my little angels, little warriors who's joining with us to support this war, and also their family members. I should thank them really, the parents, how they are motivating them. Thus, we are successfully overcoming our day-to-day challenges. Here I'm going to talk about how to stay safe after COVID-19 lockdown is over. We will have to be more careful than before and continue to practice social distancing to ensure that we remain safe. Here are 5 tips that will help. Avoid going out unnecessarily. Cover your face with a mask when you go out. Be active. It is important to stay active physically as well as mentally. Building immunity will help you to stay fit for a longer time. Stay connected. While you are not going out as frequently as before, it is important to stay in touch with people, pick up the phone and video call your family and friends, colleagues, and catch up on to stay connected. Shop online for your grocery and daily essentials which absolutely needed. While stepping out of essentials is permitted, why take the risk? There are several online grocery platforms to serve you at your doorstep. Lend a helping hand. Go ahead and donate some food and supplies to the people in during this unfortunate situation. Let us not forget about the ones that may not be able to do. Thank you for giving me an opportunity to share my first-hand experience. I'd like to thank IOC and Apollo Management for this great opportunity.
Thank you, sister. Uh, Before I go to the next speaker, I have a quick question to the to Dr. Shivabroto Banerjee. Dr. Krishnamurthy pointed out about the trigger in every state, and he said that Tamil Nadu is now closer to that maximum capacity, kind of. How is the situation in West Bengal?
See, from your journalism point of view, it's a very tricky question to a person who is dealing with COVID right at this moment, you know. And Dr. Krishnamurthy is also smiling. So I don't want to unmute myself regarding the trigger because this is beyond my scope of medical treatment. Okay, so
It's
I
okay.
should restrict myself to the medical discussion. Thank you very much.
Okay. Thank you so much. So let's go to the next speaker, Jyoti Sapru.
Hello, good morning, sir. Jyoti Sapru here. I'm a psychological counselor. So thank you so much for having me, Joyita ma'am, and especially Shahenshah sir for introducing me to this forum. Thank you so much. I'm here to talk about the psychological aspects and the behavioral issues which is related to COVID-19 patients and their families, and also to the population which is under lockdown and in isolation. This is something which we were completely unprepared for, and there are, as you all must be knowing because you all are such esteemed personalities from the medical fraternity, that we are now dealing with a new kind of epidemic which is disastrous for the mental health. And all the people who are concerned in the field of psychology, in counseling, in guidance, in therapy, this is the time I request everybody to come forward and help people in need free of charge. Just be there to help people and make them understand how to deal with day-to-day situations. That we should sanitize our hands, we should keep our house clean, and we should have good hand washing, personal hygiene, social distancing. All this is to avoid COVID-19. But what I have not seen is lot of advice that people need, that what do you do if COVID-19 actually happens to you, if it actually gets to you. And believe me, many of us will get it. So our friendly neighborhood advice, I'm not a doctor, but as a psychologist, as a counselor, I want to give some suggestions. If you get COVID-19, what should you do? You basically just want to prepare as though you know you're going to get a nasty respiratory bug. like bronchitis or pneumonia. You just have the foresight to know it might come your way. So we should be all mentally prepared for that. Things you should actually buy ahead of time. Whereas I don't understand this obsession for toilet paper, but basically all that you need is Kleenex to keep your house clean and paracetamol. Whatever your generic mucus thinning cough medicine of your choice, please check the label and make sure you're not doubling onto paracetamol. Honey and lemon can work just as well. Vicks VapoRub for your chest is also a great suggestion. A humidifier could be a good thing to buy and use in your room when you go to bed overnight. It actually de-stresses you completely. You can also just turn the shower on hot water and sit in the bathroom breathing in the steam to relax you. If you have an history of asthma and you have a prescription inhaler, make sure one of them isn't expired and get a refill. The meals should also be in good time, nutritious, hygienic, and even if it's your favorite soup, just have it with a happy mind. Hydrate, drink, hydrate, drink, hydrate. Stock up on whatever your favorite clear fluids are to drink. Though tap water is fine, you may appreciate some variety. For symptom management and fever, which is really high, you might have to consult the doctor. Otherwise, if it's just mild fever, paracetamol works just fine. Rest a lot. You should not be leaving your house. Even if you're feeling better, you will be infected for 14 other people, and those with existing health conditions should be avoided. Wear gloves and masks. Avoid contaminating others in the house. If you feel any symptoms of corona, please isolate yourself in your bedroom, sanitize your bed linen, and do not go to the hospital unless you're having trouble in breathing. If you're worried or in distress or feeling symptoms getting worse, immediately you should consult a doctor. Also, I would like to say that the state government has started tele-counseling facility to help people who are either under institutional quarantine or in home isolation to deal with stress. The counseling facility has been extended to people in quarantine or who are confined to home due to lockdown. So I would like you to note the numbers that are given in the helpline. The toll-free numbers for any kind of help from a psychologist are 1-800-313-44422. This is a toll-free number if you need any psychological help, and also 033-2341-2600. Anytime between 11 and 5 p.m., the caller will be given a time slot to get connected to a psychologist later. I am also available for online counseling anytime. Thank you very much.
Thank you. Thank you. May I now request Dr. Suman Thapa from Nepal for a quick view.
Okay, good morning, and it's been really a pleasure listening to all of you, and it has actually been very educative for me. And just a little bit of background, I'm an ophthalmologist and a glaucoma specialist, and I work in an academic institute, and it's a very large institute here in Kathmandu. So we examine over 1,000 patients every day. So as you know, it has really affected just the way we practice here. And every day we are faced with challenges on how to examine the eye, because as you know, the conjunctiva through aerosol is very infective, and the COVID is contagious, very highly contagious. So we've been taking some precautions that have been now formulated in a national ophthalmic guideline in Nepal, and how to protect ourselves by wearing eyeglasses, by wearing masks, and by wearing our gowns. And we are also doing only urgent and emergency surgery. But however, like all the countries, there is a lack of all the proper protective equipment, and we really do not know exactly how what to expect during surgeries. So all our major surgeries have been pushed out till further notice. So this is just how things are happening here, and slowly the patients are increasing day by day because there are family problems, people are coming in, etc. Now, regarding our country, Nepal, we only have 101 cases, and there has been no mortality as yet. And in this context, we can say that the prevalence of the incidence of COVID is actually very low here. However, every day the cases are on the rise. In Nepal, it is mainly the western part of Nepal that has been affected. And the reason why it has been affected is mainly because most of our workers, Nepali workers who have been in India, so they have crossed over, and the cases have come from there. And isolating them and then putting them in quarantine has been very hard. And but we still have been able to conduct very few number of like only about 50,000 RDTs and about 15,000 PCR tests. And now the problem is even more is that after quarantine, some people have again got reinfected. I mean, they have tested positive once again. So a lot of these people have moved on to the remote areas, the rural areas, which are inaccessible by cars. And people have to walk 3-4 days to go there. And now, hopefully we don't get cases in our utmost rural areas, because then that is going to be very difficult in terms of access. The plan is that the army will be mobilized to take the testing kits over there to the helicopters, because there are no motorable roads over there. So if it really takes a toll in Nepal, it's going to be very dreadful. And the other thing is, of course, like every other country, the indirect effects are on the economy, the local businesses, our own practices that have been shut, our private practices that have been shut for so long. And of course, the solutions are from the medical point of view. Of course, there's a lot of research going on as to what the vaccines are. There's so many interesting research papers that have been published as to how we should treat. So we don't have much experience in that. But what we also know is from a more humanitarian aspect is that maybe nature's kindness has been taken for granted. And although nature has not complained slowly, but in the long run, this is probably the music that we have to face. And what changes in our lifestyle are we going to do? These are very social things that we should be thinking of, because that's going to be very important for the overall general public. And what is going to be the changes in our medical practice? How is it going to affect our medical practice from here onwards? Even just by COVID, but even for other non-COVID patients. And really understanding on a more philosophical point of view is what's our realization about our absolute need? What do we really need in our lives? Are we trying to, go and get something which is beyond what we actually need? And what is contentment? And this lockdown has really told us that family is most important, and how family can actually is important in everyone's lives. And then the community, going out and helping the community, and then overall making a change and putting on humanitarian effort. So this is all that I have to say, because I really don't have an experience on treating a COVID patient as yet. But from what I have learned from all of you, it really has been very informative to me. And I'm thankful to the organizers and all you speakers for coming on to this talk, and also allowing me to share whatever whatever views I have regarding this pandemic that's going on in the world. Thank you very much.
Thank you, Doctor.
Can I ask one sentence question to Dr. Thapa?
Yes,
Sure.
yes, please. now this is the Q&A floor.
Okay. Dr. Thapa, Kathmandu is an international airport. So I have a really inquisitiveness to ask you. The Nepal is probably the only one important country all over Asia showing mortality rate 0.
Yes.
So they are having international airport, and do you know Kathmandu is a very important tourism spot. So how is it possible to having mortality 0? So can you share the idea?
Okay. So, of course, everything has been closed, the international flights, as you know, and so we started our quarantine almost nearly about 2 months ago. I mean, our lockdown. So all the workers that have come have been put on quarantine, and because we have a lot of migrant workers coming from the Gulf countries, so they have been kept in quarantine. So many have still not been able to come. So many have unfortunately come through other routes, other open routes in the border. So the mortality rate is what we know. The mortality rate of 0 is also because we haven't tested as much as we should. So probably there are cases who have died, but we do not know in the hospitals, etc. So, but so far the mortality rate is 0. What is the actual rate? We do not know. But the precautions that we have done is that we have had a very timely lockdown, and our government has been very proactive on that and has been able to do that. And also, the people have been very cooperative. So, in that way, things have helped.
Thank you. Dr. Krishna Kumar, you have a question from Dr. Banerjee. It is found in Iceland for one documented case, 2 undocumented case. In Germany, 1:5. In California, 1:80. We have tried to understand Indian status. According to mathematics, 70% undocumented. So probably we must be very aware of such undocumented death in COVID. Your turn, sir.
That's a very interesting question, that undocumented. What is that really that means? Can I have a clarity on that question?
It's there in your chat box, and I will request Dr. Banerjee to unmute and ask it.
I'm giving a small statistics. It is found out of new detected case, 15% will be serious, and out of all serious, 15% will die after 14 days. So if we start from a new date of any date, and if you go back to 14 days before, and if you calculate the maths, then if you start from new dates of a particular day, and if you go back to 14 days, and if you calculate the projected new case detected on that day, we will see always we are 70% less of the data documented on that day. So it is found in India, it is almost 70% less. As for an example, I'm giving you one data. If you calculate 4th May new date, and if you calculate 20th March, that is 14 days behind new case detected. So new case detected was 1529, but ideally that should be 4,440. So we are almost unable to detect 2,560 cases almost. So this is not applicable to India only. It is applicable globally. And in USA, even they are doing more than 2 lakh tests per day. They are also having the same data. Hence, I have given you the California data. So the main awareness out of this, what I want to mean, the non-COVID death, what we are telling, out of that, so many persons are having COVID death also.
Awesome.
We are not able to document right at this moment.
I understand. Now I accept. Now I got the idea of what you are talking about. I think it is. I think what you roughly mean is that number of tests what we are doing is much less than the real incidence. Am I correct, sir?
Yes.
The number of tests what we do, that is absolutely true. It happens to every country. Imagine our population is so much. I don't think we'll be able to do so many number of tests what we are doing. see, as far as death proportionately, death when there is a COVID, where it undocumented death also, it might be COVID also, it might happen even in the household, the natural death can happen, which we do not know also. In rural areas also, some deaths do occur, which might be COVID, which we do not know also. I agree with you, sir. But there is unavoidable. But how the statistics is going to come, how it is going to be proven, I think it is really hypothetical actually.
Yeah. It's all a bit mathematical, so we have to depend a lot of variables. Definitely, I fully agree with you.
Fine. So, would you like to come to a conclusion on that, sir? Do you mean to say that?
No, yet we are calculating. We are always, like you, I am also studying and studying and studying. So what I got the idea, I am only sharing with you.
Fine.
Because I have seen someone is smiling, so I got inspiration out of it.
That's good, sir. Okay.
I have a question to two doctors.
Tell me, sir.
While the test to population ratio is definitely low, right? Pakistan is a shade ahead of us. In fact, but if we look at the number of cases, number of tests that we are conducting to find one case, this ratio is increasing, which means that we are trying harder to get a case. Right now, it is around 20. We conduct 26 cases tests to get one confirmed case. This was around 9, I think 9 or 10, 2 or 3 weeks ago. So how do you look at it? This ratio, what is the real life context?
Should I react?
Yes, sir. Dr. Krishnamurthy.
Okay. Now see the statistics, how you are extrapolating the statistics, that is the idea. Now, if you discuss test in ratio to the confirmed case, then it is 26.2 tests to be done right at this moment for detecting one positive case. That is one idea. But if you convert the number of tests against the population, then we are absolutely in the nadir situation, because challenge is our population. Okay. So I am happy with my country's position right at this moment. We are taking 26.2 tests for detecting one positive case, where in UK it is 4.5, where in Italy it is 10, where in US it is 6.1, where in South Korea, who are almost at the base, they are 54. And Vietnam, who has declared they are almost corona free, probably they are the only country they are telling, and they are doing 934 tests to detect only one positive case. So
Taiwan is there. Taiwan is very good.
So among all these, if you tell, then I am happy. But if you tell in other way, in comparison with the population of our country, then if you convert it per thousand or per million, then I am not at all absolutely happy.
A little less than one test per thousand.
Okay, sir.
Dr. Krishnamurthy, sir.
Can I have a comment on that, sir? Sir, you were saying that 2 weeks back, for every 10 tests, 1 was positive. Now it has increased for 26, 1 is positive. Am I correct, sir? Can I get your question correct?
Yeah.
So the reason for that, which I was mentioning, the trend, you understand this, sir, how we are doing the trend, how we are testing now. We are going on now, not just like that, catching hold of the people and then doing an idle. See how we do it now, a contact tracing now. Suppose we get some trigger or a cluster, we get some hotspots. We start doing the number, we start increasing the number of tests around that only. See, that's how the number of tests are increasing, and you should be really happy. Out of 26, only 1 is coming positive. If out of 26, if 20 is positive and 10 is positive, we are in real danger. In real danger. I think you must be happy. Don't think that we are unnecessarily testing. We are testing the population around a positive case, and out of 26, only 1 is coming positive. We must be happy that the lockdown and the patient's awareness is quite good. I think you should be feeling happy about it.
No, that is what I said, that there is a positive trend, while countering.
Exactly.
So, in fact, I was checking, the USS figure is around 6.
I still remember, can I share my relative's experience in France?
Yeah, please, sir.
Yeah, so I have my brother-in-law in France who had some, during this season had a respiratory difficulty. And while talking to him, he was having few coughs. I told him that you are not all right. You please go and check. The France statistics is not good. And he took an appointment and he went for a CT. CT showed a CT severity index of somewhere around 10 to 12. And I asked him to go for COVID testing. They said, no, you just stay back home. I think your severity index is not so great. And then they gave a medicine on video consultation. He improved very well in 2 weeks' time. So I think the testing need not be aggressive. At least for the population, when there is a hotspot or a cluster zone, I think we should go around testing those people in order to pick them up.
Are we taking advantage of rapid tests in clusters?
There is no other. So the turnaround time, in clusters and in clusters and hotspots, there is no other go, sir. The turnaround time for the RT-PCR is somewhere between 2 to 5 hours, actually, if I am correct. 2 to 5 hours for the turnaround time for the RT-PCR, that we will not be entitled to do in these cluster zones, cluster and hotspot areas where there is no other go. You have to go for the antibody rapid test kits, sir, though the reliability is not so great.
Okay. So anyone is having a question?
Can I comment on the rapid antibody test? One
Yes,
comment?
sir. Yes, sir.
Everyone will be happiest if we are getting rapid antibody test right at this moment in India, but very unfortunate we are not having rapid antibody test right at this moment in India. But we are totally depending on RT-PCR test. That is very unfortunate, number one. Number two, regarding the cluster zone, was what Dr. Krishnamurthy is telling, I am fully agreeing. We have no choice. We have to do thoroughly. So that is accepted. But what is the idea? We have to keep our green zone well protected, and we have to make our country green. Now, few months back, we have seen the color of country red, then red and orange, then red, orange and green, and we want to see before lockdown is over, we want to see color of country is green. So protecting green zone is very much challenging and important. And for that, if we have to do RT-PCR, that will be very much expensive. So the idea is, if we can do pool test for those green zone, we can utilize less number of tests to cover more population over the green zone, and we can keep a surveillance on the green zone so that we can protect green zone properly, and we can keep our country greener and mostly green.
Thank you, doctor. Shomik has a question. It is mostly in the lines of there is basically two questions from common man's angle. So I am just putting it together. Is that whether there is how much virus, what is the quantity of virus that one gets into contact with, has anything to do with catching the disease, and secondly, whether life will ever be normal after COVID. Yes, Dr. Krishnamurthy.
Yes, sir. Regarding the quantity of the virus which is needed to infect a man, is that the first part of the question?
Yes.
Yeah, I think there are no proven studies to say that this much number of virus is necessary to infect. I think the studies of, as far as I know, there are no studies to say. But the second part of the question, definitely life is going to be good, but it may take a minimum of 3 months, even up to 6 months. We have to live with this virus, maybe not with such severity actually. Definitely it is going to be. And regarding the comment which I would like to make, when we do tests for the repeated tests for these patients, and even some viruses which are inactive can give rise to false positive test actually, which we are really unable to discriminate whether they are really live or dead, or it is very difficult also. There are some tests which come as equivocal where there can be an possibility of late amplification. I have got a question to a psychiatrist, sir.
Yes, sir. Please, she will be very happy to respond.
Now, this is our real-time experience. Actually, we have been having more than depression. We find most people are agitated. Actually, we have found a number of people who are agitated. They really do not know. They don't believe on their pulse oximeters. They do not believe on their CT scan findings. When we find that sometimes we to break a chain of transmission, we are compelled to keep some people on a quarantine and monitor these patients, and we get these people on little agitated. They are knowledgeable people. They convert their knowledge into real over enthusiastically. They become agitated. Yes, sir. I want the psychiatrist. Can we do something more than, because regarding counseling aspect, we really fail and become fatigued. And your comments, please, on the treatment perspective.
Yeah, sir,
Yeah.
is that for me?
Yeah.
Yeah, but I'm a psychological counselor. I'm not a psychiatrist. I do not prescribe medicines. And like sir is talking about aggression, that is what I was coming to in my speech also.
What the doctor said is that that there are people, especially from a class like us, right?
Yes,
Who
yes.
very trust to things, so they are arguing with contesting even whatever is normal for the doctor to test and get the result, and is contesting everything. So what he said is that people are basically in agitating mind. And
Yes,
what
sir.
about it? How
Yes,
to?
sir. That's exactly what I was telling you previously also, that we need to give them a lot of information. It mostly the aggression is coming from ignorance. They have a fear of uncertainty. They have a fear that this thing is going to go on indefinitely. So a lot of information, proper information needs to be provided so that they feel secure and they feel that this is not the end of the world. Yes, the pre-corona age may not come back, but we will be surviving. There are so many cases who have healed, who have come out of it in a positive and a strong way. So we need to give proper information to these people so that once they get out of their ignorance, they will feel less agitated, they will be less aggressive, and they will be able to, heal themselves mentally, physically in a better way. So I feel that ignorance is something which causes more uncertainty and aggression in people.
But doctor is talking about people who are from the so-called knowledgeable class.
I understand. I understand.
It's only the fear of indefinite,
I understand
how long the lockdown will go on, when we will be back to normal.
Why I raised this question was, I'm sorry, what you said is absolutely true. What given the amount of time, we have 6 hours of duty for staff nurses and doctors over there with so much of PPE and struggling with sweats and everything. They are there. Sometimes these people take most of the times rather than the real sick ventilated patients in the ward actually. So the administrators, we find a real tough time. So that I raised a question. I think we'll find it a little
So
treatment
like I said,
perspective.
it's a basic insecurity that they feel, which needs to be tackled.
And one more experience, sir, to the moderator, let me talk about the persistent positivity in few patients. Though they become asymptomatic, though they have become less symptomatic, there are certain number of patients who are persistently positive. With, I think I should share it with or Dr. Subrata Banerjee, there are patients with persistent positivity even after some 15, 20 tests, even after 1 month they are positive. There are certain group, I think it needs little more investigations and trials, which I thought I should share with you.
This is a really big topic, and I think we have already crossed 1 hour 20 minutes with our discussion. And Dr. Krishnamurthy's phone is continuously ringing. That I understand.
So if we can wrap up, and before that, I have one question to doctors: is why 70%? That is, of course, a global average. Is that most men are most prone to get affected? But in India, I was just seeing the infected age group, and it is between 20 to 40 who are the most affected. I don't know about the age mix among persons who died. So why the 20 to 40, this age group is most affected in COVID?
Now see, we have to understand the age prevalence of the COVID. Usually COVID is not only infecting, it is rather more serious in elderly, but it is infecting the whole population. Now let us look at Italy. Say in Italy, 22% of the total population is elderly population. Now if you look at US, it is 15% of the total population is elderly population. Now if you look at India, according to last census, it is 6.4%, and right at this moment, if you calculate as of now, it is almost 10% of the total population is elderly population. Now, if you look at the median age, in Italy, the median age is 43. In USA, the median age is 38. In India, median age is 28. So,
okay, I get your point.
I think my statistics is answering.
I think I agree with him that statistically, for the age epidemiology, what he is saying is absolutely true. From the medicine perspective, I will tell you one more point. The non-communicable diseases, which we take it as comorbidities in this situation, is very much on the rise in countries like India. I think the non-communicable diseases are much more prevalent in India as more and more youth population, as Subrata Banerjee was pointing out. I think it automatically comes in category B. I think we have to find more and more, we have to spend more and more time in tackling this non-communicable diseases, which Apollo's one main target is to target these non-communicable diseases. This is what I wanted to tell about, sir. Yes, sir.
Thank you. Thank you. Thank you, doctor. Yes, NCD, we can see that from the statistics, the NCD load has increased substantially in the country data. When you see the CD load and the NCD load has come down drastically and the NCD load has gone up.
That is why, sir, the importance of master health checkups do clearly have a role in our day-to-day practice and health perspective. I think as deviated or distracted by so many persons, that master health checkup has been an earning point of view for the medical professionals or health sector. It is not so, sir. Actually, when it is done properly and judiciously, I think the master health checkups will definitely reduce the non-communicable diseases to a great number, sir.
Thank you. So there is no more question, I see. So let's wrap it up. Actually, we are supposed to close by 1 hour and it's now 1.5 hours. So excellent discussion. I don't think that I have too much to wrap up. Some interesting points came up. It is Dr. Krishnamurthy pointed out the gravity of the scene. Yes, in certain parts of India, things we are seeing the data. So nothing to further straight. What strategy the country should take on testing, and the strategies has to be dynamic according to the situation. How to take tests to the doorstep. Yes, Dr. Banerjee said, and that's a very crucial issue. Considering the paucity of infra, the taking everyone for testing to the hospital and blocking the beds, and thereby increasing the possibility, if at all, of getting the uninfected infected, right? So all these things are there. We really have to keep on changing our strategies, and as finally the green zones, we have to ensure that the green zones don't become red zones. Across the world, people who had once been recovered are coming back again into the fold. So with that, I wrap up this session.